Well, good evening, everyone. My name is Rakesh Patel. I go by Rock, and now that we're all one family, please call me Rock. I'm a radiation oncologist. I'm a medical director of the radiation oncology program at the Cancer Center in Pleasanton. You're going to be hearing from a number of my colleagues, and all of us have a joint vision, and this really started a few years ago when a handful of us that were treating with breast cancer for a number of years and had academic experience and broad experience throughout the Bay Area said, you know, we really want to be a nationally accredited breast program. We feel that we have the talent, we have the technology, we have an educated patient base, we have a terrific hospital partner. We feel that we deserve accreditation. And it turns out that we weren't quite sure what we were getting into because there's a lot involved in being a nationally accredited breast program. Quite frankly, in 2014, breast cancer is very personalized. It's very focused on an individual. I came from an academic background in Wisconsin, and I used to tell my residents is that we don't treat textbooks, we don't treat cancers, we treat people. And that's a very different approach that I enjoy every day now being in community practice for the last 6 years compared to an academic setting when you're pushing a protocol or working only in a very narrow framework. Here we get to offer academic medicine in a community setting, and my colleague and partner, Dr. Sawhney, states that all the time, and he really lives it and practices that way, and you'll be hearing from him a little bit later. We have a packed agenda, and we're going to cover a number of topics, and I think you're really going to enjoy this evening. I'm not going to give you a long introduction now, but let's jump right over into the first speaker, and then I'll come back time to time and speak about different things that revolve around our breast program and some of the key individuals that have allowed us to shine. Well, it really starts when you get diagnosed with an abnormal mammogram. That's when your breast cancer journey begins. And so we think it's very appropriate and have started our symposium with this first speaker. She's a terrific speaker, an excellent radiologist. Her name's Dr. Chang. She's a board-certified radiologist who currently works at the Imaging Consultants Medical Group, Bay Area Imaging Consultants Group. She's the medical director of Diagnostic Imaging and co-chairs the breast steering committee at ValleyCare with myself. She's fellowship trained at Stanford University, who unfortunately lost to Notre Dame in the last throw in the fourth quarter on 4th and long, but that's not important right now. She was a co-chief resident I went to Notre Dame, for those that didn't know. She's a co-chief resident at Columbia Presbyterian Medical Center, and she got her medical degree on the East Coast in New Jersey. And I'm happy to have her here today to talk to you about current screening recommendations for breast cancer. Dr. Chang, why don't you start us off?
Thank you, Dr. Patel. Welcome, everyone. It's good to see everybody in the audience here. I'm excited to be able to talk to you a little bit about current screening recommendations. There's probably a little bit of confusion out there because of what's in the news and also because of the new hubbub and the discussions about breast density and what it means. So we'll go over some of that this evening. So there are various methods of screening for breast cancer. You can see the list in front of you here. I'll be mainly concentrating on the top 4. Breast tomosynthesis is something new. Some people call it 3D mammography, and it's available at some academic centers and slowly catching on. Dedicated breast PET scanning is something that's very high-end, cutting edge, and not widely available. Not even the academic centers all have this. And then thermography is something that people talk about. I really don't feel very strongly for it, but it is something that sometimes gets asked. So mainly the top 4 things are the mainstays of screening these days, and that's what I'm going to concentrate on. I cannot overemphasize the importance of a self-breast exam. I think a lot of people, when they think of screening, they think of mammography, and that's about it. But there are many times where the woman will find something herself, or the doctor will find something on physical exam before it's time for a mammogram, or because mammograms haven't been done in the past several years. And there are different ways to do the breast self-exam, and you can figure out what works best for you. Here on the diagram, you can see different ways you can palpate the breast to look for lumps, thickening, abnormally stiff tissue. things that would be an altered breast, things that would be new for you. And if you're not sure, the first time you feel around the breast, you're usually going to feel a million different lumps, and you're just going to give up and say, oh, forget this. The entire thing is abnormal. But really, I would encourage you to stick with it. Even make a log if you want to, and each time you examine yourself, you will figure out familiarity with the breast and realize that you're getting used to knowing which parts of the lumps and bumps in your breast have always been there and are normal for you. There are other things other than just lumps that you can look for on your self-exam, and these are some of the symptoms that you can look for. Just recently, I saw a patient who had really almost an absolutely normal mammogram, but her physical exam was abnormal, and she noticed it herself when she looked in the mirror, and the shape of her breast was different on one side from the other. She basically saw this thing at the bottom of the screen you see here called puckering, where the skin looks like it's being pulled in one spot. You might not see it just looking straight on, but if you raise your arms overhead, you might see it. So these are different things that you can also look for. Mammograms, of course, are something that we always hear about and people are going to be talking about. It is not replaced by ultrasound or MRI. Even though it's not the perfect test, and even though it doesn't detect every single cancer out there, it's the one that's been tested over time by many, many different people with randomized controlled trials, which is the best kind of medical study that we can perform to prove its effectiveness. The current recommendation from the radiology societies is to start annual mammography at the age of 40. And if you have a first-degree relative, so I'm not talking, your third cousin or your grandmother from your stepfather's side. I'm talking about your direct mom, your direct sister. If they have had a premenopausal cancer, let's say 39 years of age, then you would actually start your screening mammograms really young at 29. Okay, so the recent discussions about breast density. This is a map of the United States, clearly, and the states are colored different colors depending on what they've enacted recently with regards to breast density. So California has enacted a law about letting women know about their breast density on mammograms. Some states, even the ones with the little stars on them, have enacted laws for insurance companies to cover additional screening. So the California law is called SB 1538, and it started mandating us to let you know about breast density in April last year. And so if you see a new blurb on your letter that you get at home that says, oh, you have dense breasts and this could mean this, or this is why this information is now being distributed. We've always seen it on your mammograms, but there hasn't been the need to tell you about it, and I'll explain why. So first of all, what is a dense breast? You have two mammograms here, one on your left side, which is the dense breast, and one on your right side, which is the not so dense breast. They're both normal. So if you look at this picture on your left, you can see there's more of this white glandular tissue, and that is what's called density on an X-ray or density on this mammogram. It's normal tissue, it's glandular tissue, it's the part of the female breast that changes with our periods, grows with menstrual cycles, and also can give rise to cancers. And everybody has kind of a different variation of how dense their breast can be. So it's normal, and you can't feel how dense your breast is. You can't judge by whether you're tall, small, wide, or skinny, how dense your breast is going to be. It's really kind of just what your genes dictate for you. So in the American College of Radiology, we categorize breast density into 4 different categories. On your left is the densest. You can see almost the entire breast is all white tissue. Then we have heterogeneously dense, which means kind of patchy dense tissue, scattered densities, which means little bits of white tissue here and there, and then predominantly fatty breasts, like what I showed you on the previous screen, but it's mostly gray, normal fatty tissue. If you have any of the first 2, the very, very dense or the heterogeneously dense, then you will have that blurb at the letter that you get at home saying you have dense breast tissue. So what do you do with that? So now I'm told I have dense breast tissue. Okay, do I need an extra screening test? Do I go to my doctor? Well, remember it's normal, and actually about half of the women out there, half of the mammograms that I look at will have dense breast tissue. So it affects a lot of people. And why is it important? It's important because of a few different things. There's a theory out there that if you have more glandular tissue, that tissue is inherently different. It somehow behaves different over your lifetime than the fatty tissue. And it can actually be more active, it might have more cell turnover, it might be more predisposed to having mutations or breast cancer. And then the other theory, which I definitely believe in as a radiologist, is that having dense breast tissue makes your mammogram harder to read. It can actually mask a cancer. You can have a white dot, a new cancer show up in the breast, and it's just harder for us to see. And what helps us in radiology is looking at all of your prior mammograms and looking for changes in patterns. So even if you have a very dense breast on mammogram, you should still get your mammograms. We definitely find cancers in those dense breasts that we see, and it is worthwhile to still get your mammograms. So what do I mean by masking? I think if you look at the picture of Where's Waldo on the beach, pretty much all of you can see there's Waldo, right? It's pretty easy to find. So if the beach is analogous to the fatty breast tissue, and I'm gonna make a cancer show up there, you can see that there it is. It's pretty easy to see. So there's no masking going on in this particular breast. So I challenge you to find Waldo in this particular picture, and I will tell you, it took me a long time. I was sitting there really, eyes to the monitor looking for this little guy. And it's much harder to find. I can find him, but it takes me longer, it's harder, there's a lot of noise, there's a lot of other people on the beach. And so if you look at this mammogram, keep your eyes on the screen, I'm gonna have a make-believe cancer show up. Here it is, a blob, and it's gonna hide in the dense breast tissue. So it's much, much harder to see, right? It's there, and if I look at prior mammograms, I could probably recognize it. I hope that I can recognize it, but I have to pay extra attention to where the dense breast tissue is, and it does make the mammogram a little bit harder to interpret. Okay, so how does the presence of dense breast tissue affect risk? Can we quantify what I was talking about in terms of masking and in terms of inherent activity of the breast tissue? Some of the articles out there have done statistical analysis on what your chances of cancer are if you have a very, very dense breast compared to a predominantly fatty breast. And the maximum difference is about 5 times the risk. In between the different categories, it's about 1.2 times the risk. And if you compare yourself to other people in the same age group, it's about 1.2 times the risk. But if you take all comers and you take the extreme, the very, very fatty breast, and compare it to the very, very dense breast, then the maximum difference is going to be 5 times the risk of breast cancer in the dense breast. And I don't want people to think that that means, oh my gosh, it's an astronomical risk of breast cancer. It's 5 times over the chance of the average person having breast cancer, which is actually fairly low. So to give you an idea, I should be reading about 1,000 mammograms, 1,000 different patients' mammograms to find one cancer. And so if we make all of those 1,000 mammograms dense breast tissue, then maybe I will find 5 instead of 1. What do you do about having dense breasts? Do I need extra screening? Do I not need extra screening? Maybe I'll pay more attention to doing my self-breast exam. So this is one of the alternatives, is ultrasound screening of the breast. It's the same technology we use to do ultrasounds of babies, and we apply it to the breast. So if you look at this mammogram where that dense breast tissue was, where I have put that imaginary cancer, and we shine the ultrasound probe on there, we actually get more information about the tissue. We can see these little fluid pockets, which are normal benign cysts. So we can see that there is something hiding in that breast tissue. For this particular person, it's not cancer, but you can see through it a lot better. And how about for this mammogram? These are 2 views of the same breast, and there's this little circle. Is this a cyst, or is this a solid lesion? On this particular mammogram, I can't really tell. It's very smooth, it's well-defined, and it could be either one of those things. If we do ultrasound, these are probably what I'm going to be thinking. Is it going to look like this nice, smooth, oval, friendly-looking little bubble of fluid, which is a cyst? Or is it going to be this solid lesion? It's gray in color, and it has these little lumps and bumps that come out of it. So this is an example of a 3D breast ultrasound. It's a special kind of screening breast ultrasound where we scan the whole breast. You see this cyst up here? We scan the whole breast at the same time. We have a special machine that does this. And if you get a screening breast ultrasound, this is the kind of ultrasound that you would get at ValleyCare. The advantages of ultrasound for screening are that it's 3D technology, which is really nice. It's nice to have that on top of just regular handheld ultrasound. There's no radiation. There's no compression of the breast like there is with mammograms, so it's a much more comfortable exam. And compared to some other forms of screening, mainly MRI or those high-end PET scans, things like that, it's actually pretty affordable. The disadvantage is, I put cost in both columns, is because it's not yet covered by all insurance companies. Unless you're super, super high risk, you have a gene that's related to breast cancer, you have a very strong family history, or if you've had your own personal history of breast. If you don't have those things, then the insurance companies might say, well, it's kind of optional, it's up to you. So you might have to pay for it out of pocket. Hopefully that will change in the future. And with any screening exam, there's always the possibility of having something called a false positive, where we think there may be something abnormal, but we're not quite sure, and so that leads to more testing, maybe an additional ultrasound or maybe an additional focused mammogram, so you would have to come back and kind of have that worked out. As far as availability, I'm very happy to say that it is available at ValleyCare, so you have that option here. It might not be available at all places, but in the Bay Area, you do have ValleyCare you can come to for 3D screening ultrasound. This is another example, and so as the movie clip goes through, I want you to keep your eye on this part of the breast right here, where you see this dark spot, and this dark spot has these little projections coming out of it. It doesn't look smooth, it doesn't look black like water does on ultrasound, and this was a cancer. And there was a lot of white tissue that was around this, so on mammogram it might have been hard to see because the white tissue would have been white on mammogram, and the cancer would have also been white on mammogram. Okay, so I want to move on to MRI. MRI is a high-end examination. It takes a lot longer. You have to go into the magnet, which if some of you have gone into a magnet before, it can be kind of a little bit of a daunting experience, but it's painless. It just takes a little while, and it gives a lot of tissue detail. Okay, so sensitivity, advantage is sensitivity, which means that MRI has a very high detection rate of finding cancer. Is now, most of the time, when you look at the more modern studies as compared to 10, 15 years ago, we've gone from being 80% sensitive, 90% sensitive, now to over 95 to 99.9% sensitive. So it's a really, really good test if you're looking at that. There's no radiation. It's not CT, it's MRI, so it uses magnetic resonance frequency. Won't go into physics of that, but it's not radiation. It's great for high-risk patients. So for a lot of people who fall into the category of what's formally designated as high risk, so that means over your lifetime greater than 20% chance of having breast cancer over your entire lifetime, not just the next 5 years, but over, when you're 82, you still counting that into this calculation. You would qualify for annual MRI screening, and that is covered by insurance most of the time. If it's not covered by insurance, it is a more expensive test. There are also false positives for MRI. And you're also faced with availability. Not everybody has it, and if they have it, can they do MR-guided biopsy? Those are things that we have to think about. In terms of comfort, you're lying on your stomach like that diagram had showed you, and the test usually takes anywhere from half an hour to 45 minutes, so you have to stay pretty still during that time, and it involves an intravenous injection of contrast, radiology dye, special medicine injected into your veins during the scanning to evaluate blood flow in the breast. So these are some pictures, examples of what breast MRI looks like. You're lying on your stomach, so that's why the breast is pointing downward toward the floor. And we look at the architecture of the breast tissue. We look at how much fluid is in the breast tissue. This bright spot right here is related to inflow of that contrast that we've injected, so it lights up in tissues that are taking up more blood flow than the rest of the tissue. We look at the shape of this, and this is a cancer. And we also do quantitative analysis to actually measure the amount of blood flow and enhancement, and that also gives us an idea of the behavior of the tissue. So this is another example of cancer. It looks very different from the one on the last screen. You can see there's lots of little dots in this breast, and the cancer tissue will enhance earlier and brighter than the other tissue around it. And so I compare that to this breast, which you might say, oh my gosh, half of that breast is involved with cancer, but this is an example of one of those false positives, because when we go back into the patient's MRI history, we can see that her pattern of enhancement changes from year to year, and a lot of that is just related to what's going on with her hormones, where she is in her menstrual cycle when we're doing the imaging, and how that affects your glandular tissue. So, some women have very sensitive breasts. They know where they are in their cycle just based on what the breast feels like. Is it hurting me? Do they feel swollen? Are they very sensitive to touch? And that's reflected in this blood flow pattern that we see here. So what test is right for me? I've given you a bunch of information. So self-breast exam, yes, everybody, okay, should be doing self-breast exam. Mammogram, almost everybody. I think if you're 40 or above, you should be having it annually, and then depending on your family history, maybe a little bit earlier. And then ultrasound and MRI, possible. Certainly options. We've talked about what goes into deciding whether or not to get ultrasound or MRI. So You get a self breast exam, you do it for yourself, your doctor does it for you. You get your mammogram, and you get this letter, and it says, you have dense breast tissue. Well, okay, now what do I do? Do I need to get that ultrasound? Do I need to see if I need to get an MRI? What you should do is look at your medical history, go over that with your doctor, and these are the things your doctor might ask you. What's your family history, your mother, sister, daughter, any ovarian cancer, other female-related cancers in the family? How about a male relative that has breast cancer? Or if you've had a previous biopsy of the breast, what were the results? Was it something that was a high-risk lesion? So these are fancy words for a special high-risk lesion, atypia, atypical ductal hyperplasia, lobular hyperplasia, or something called lobular carcinoma in situ. It has the word carcinoma in it, but it's actually just a high-risk benign lesion. If that history is positive, then you should probably undergo dedicated calculation using established risk models. And our oncologists here are very familiar with that. Some of your doctors out there may already be familiar with that. And that's where you get the number of whether you're less than 20%, greater than 20% lifetime risk of breast cancer. If the answer to these questions is no, well, you can kind of stop there after your mammogram. Additional imaging is optional for you. And you can decide what would be right for you depending on how you feel in terms of what do I need to do to make myself feel comfortable about having screened myself well enough, how about cost issues, and then can I deal with what the occasional false positive that happens? What do I do with that? Am I going to be comfortable with going back for additional testing? So let's say your family history is positive, you get your risk assessment, and you do have a high lifetime risk of getting breast cancer. Actually, then the recommendation is mammogram plus annual MRI. So you would get once a year mammogram and once a year MRI. That's very well established. That's recommended by the National Cancer Society and all of our subspecialty panels. If you cannot get MRI for various reasons, claustrophobia, or you just can't get the contrast, or there are issues with kidney function, then you should think about breast ultrasound as a good alternative. When we put breast ultrasound together with mammogram, we actually find an additional 1 to 4 cancers per 1,000 patients that are not seen on mammogram, and the combined sensitivity of those together is over 95%. If your risk is not high, then like I said, you have the option. You can decide for yourself what's best for you. And since MRI is a much more involved exam and it's very expensive, breast ultrasound can be a quite reasonable alternative. So if you need more information about what I talked about today, then take a moment to write down this website. It has information for your doctor as well as information for you. I think it's a pretty good, well-built website. It came out during the time that California started this state law to answer a lot of the questions that arose from that. And it definitely goes into more detail about the things that I touched on tonight. So thank you very much for your attention. If you have any questions, I'd be happy to address them.
Well, thank you very much. We're going to essentially hold question and answers and some other, the raffle and other aspects of it until we get through the next speaker as well. Well, the next speaker is well known to this community. His name is Dr. Rishi Sawhney. He is currently the chair of the Cancer Committee at ValleyCare. Our practice has been around for a long time in the Tri-Valley, and the father of our practice is Dr. Peter Wong. Many of you may know him. He started the practice 36 years ago, and our joke is that if Dr. Wong is Mufasa, certainly Dr. Sawhney is Simba. He has carried us. He's our leader in our practice. He's really coined the mantra that each of us practice every day, and it's in our logo. And he lives it in the way he approaches patient care. And it's to provide comprehensive, compassionate, and personalized cancer care to the community. And it's certainly true in breast cancer, as you've seen some of the innovation and advances on the breast imaging side, allowing us to find cancers very early in their evolution at a time where targeted treatments are available. We're going to hear about how this impacts our ability to care not only locally but also systemically with Dr. Sawhney. Well, he is very accomplished. He is a recipient of numerous awards, including the National Research Service Award from the NIH. He's presented his work at national meetings and published in peer-reviewed journals. He's done his fellowship in hematology oncology as well as geriatric medicine, geriatric oncology at UCLA, where he worked specifically at the Revlon Breast Center, which is very well regarded. Many of you may not know that many medical oncologists, although they have a lot of experience, don't have a subspecialty focus in geriatrics as well. And as the population continues to age, and that segment is at a higher risk of developing breast cancer, doing specific assessment for that age cohort is incredibly important and one that we value. He also did his chief residency in internal medicine in the Midwest at Case Western Reserve University program. And around this time of the year, around Halloween, is when I'm reminded that if I'm Robin, he's certainly Batman. Dr. Sawhney, it's my pleasure for you to bring us up to speed on what's happening in breast cancer. Thank you.
Thank you, Rakesh, for the generous introduction. I would like to begin by first thanking everybody who's here in the audience. It's because of you that we are here and we have this symposium. Learning about this disease, I believe, is kind of the first step to beating this disease. More information, more awareness. I'd like to thank all the sponsors and foundations that are here today that support us, and certainly ValleyCare Health System that hosts this symposium. So the focus of my talk tonight is I wanted to keep it very quick-paced. It's not the whole Bible on breast cancer, but certain specific aspects of breast cancer as they relate to personalized testing. How do we figure out who needs what? And even though we know breast cancer is one disease, we truly believe that it's actually 300 diseases masquerading as one. So personalized genomic testing for breast cancer. Personalized breast cancer therapy. Again, one size doesn't fit all. This can relate to chemotherapy, hormone therapy, targeted and biologic therapy. Personalized supportive care. Chemotherapy can be given, but how patients are shepherded through that experience is what makes the difference in our minds in a good outcome and a not so good outcome. And then a little bit about personalizing survivorship and preventing cancer. So I like to start all my cancer talks with this slide because this slide sort of encapsulates what cancer is. It is unfortunately a byproduct of normal cell division. Many cells in our body are constantly in a state of division. They are dividing. And as you can see in the top part of the slide in this cartoon, it's one cell that makes an error and can't stop dividing and divides perpetually is what gives rise to cancer. So believe it or not, no matter what cancer you have in any part of your body, it's a monoclonal process. Each cell is exactly the copy of the original cell that it started. Treatment is already personalized a lot in breast cancer just on the basis of stage. So this slide shows you that, based upon whether the tumor is in the breast and the lymph nodes, breast, nearby lymph nodes and distant lymph nodes, and then unfortunately in a small minority where it has traveled to some other organ, we can stage it into 4 stages, stage 1, 2, 3, and 4. And based upon that stage, we personalize our treatment. But still there is a lot of questions that remain out there. So the questions are, can we better understand this disease? Is this truly one type of cancer, or is it many types of cancer masquerading as one? Are we overtreating some patients with early stage disease? That's a big question out there. Does every small tumor need to be, as we say in our parlance, nuked? Can we figure out in whom it's going to come back? Why does it happen that the same type of patient, I see 3 patients with stage 1 on one day, all 3 are seen by the same doctor, probably I'll give them the same treatment based upon national guidelines, but why does in some the disease come back and in another one it never comes back? We believe a lot in certain cancers, in certain type of breast cancers, giving anti-estrogen therapy. Everybody gets the anti-estrogen pill, but in some still the cancer comes back. Why is that? Is there some sort of resistance? What about targeted therapies? Can we use a targeted agent indiscriminately, or can we figure out how to target it appropriately? And then certainly in advanced stage diseases, those unfortunate patients in whom they present with disease that has already spread to other organs upfront, or those unfortunate few who will get cured, will get chemotherapy, and later on will have the disease come back. At that time, what can we do to help figure out how to best treat them? So this is what breast cancer today looks like to your treating physician. It's not one disease. This is actually a gene array nomogram picture here. It's a very famous picture. You can't go to a breast cancer talk today without seeing this picture. It was published in 2001 in a journal. The red and green dots on that picture are actually over and under expression of genes. So this is a microarray, which allowed us to figure out that breast cancer is not one, but molecularly, under the microscope it all looks one, but molecularly it can be divided into 5 different types. Luminal A, luminal B, the so-called normal type, the basal type, which is usually the bad actor, the triple negative, and the HER2 type. So based upon this, there is a better understanding of the biology of the disease. This is, again, a follow-up. So this big experiment was performed. Breast tissue was analyzed on a microarray device. And certain genes collected together in those groups. In the top part of the slide, you see how they kind of collected together and how we subdivided them. Now, was this just a scientific experiment and a lab experiment? Well, the authors of this approach actually went back and looked at a data set and said, does really classifying breast cancer in these so-called 5 types really mean something to the patient? And this is overall survival graph that shows you that based upon the type of breast cancer that these patients have, irrespective of the treatment they got, irrespective of the doctor they saw, that truly there is a difference in longevity or survival. So you can see actually the red line, which I talked about, is the basal type. The survival was the shortest. Then you have the HER2/neu or the ERBB2 type, and then luminal A, which is the dark blue line on the top, had the best outcomes. And hence this question about are we over-treating, under-treating some patients, because some patients' biology is dictating what their outcomes are. Doesn't matter which doctor you're with, doesn't matter what treatment you're getting. So it's time that we look at this biology and then fashion treatment. Thankfully, most breast cancer patients in our country will get screened, get diagnosed early, as you just heard in Dr. Chang's talk, why it's so important to get caught early. Why? Because once the cancer is caught early, it can be taken out by surgery. You're essentially cured, but many patients will require additional therapy to prevent the cancer from coming back. So today, with some of the tools that were previously not available, we were looking at treating everybody, but increasingly now we are beginning to figure out that not all patients with early stage disease benefit from this chemotherapy that we give them. So there is this one group that will not benefit and will certainly have toxicity from the treatments that I give them. A second group that will benefit from the treatments that I give them, truly reduce their risk of the cancer coming back, but will have some toxicity. So there it's worth the effort, right? They got sick from my treatments, but at least we prevented the cancer from coming back. Then there's the group which would benefit and surprisingly tolerate the treatment very well. They kind of won the jackpot, got treated, reduced their risk of the cancer coming back, and didn't suffer any horrible consequences. And then there is that group that didn't get any benefit, neither did they have any toxicity. So the question was, how do we help figure these questions out? That's where some of these assays are coming into play. So what I've put here is just 3 kind of assays that we use for profiling patients with early stage breast cancer. The first one that was approved was Oncotype DX. It's a 21 gene assay. This is just a summary. I'll go over with them a little bit more in detail. The first major trial was published in 2004. It's a specific patient that this assay can be applied on. I can't use it on patients, but in an estrogen receptor positive, small tumor, node negative patient with invasive breast cancer, it may be able to help us answer questions in what the patient's risk is of the cancer coming back and whether they would benefit from chemotherapy. The second one is called MammaPrint. It's a 70 gene signature, so a larger panel. First major trial in 2002. Again, applied to a specific population, was FDA cleared. And then the third, which is kind of the latest kid on the block, called Prosigna, which is a 50 or a PAM50 platform, but it's 46 genes that are truly being looked at. First major trial published in 2013. And again, a selective population of patients to see whether they would benefit from anti-estrogen therapy. This is Oncotype DX, looks at 21 genes. As you can see on the top part of the slide, these genes are broken down into what they tell the tumor to do. Some genes tell the tumor to keep dividing perpetually, right? So that it keeps growing. Some genes and proteins tell the tumor cells to start invading into blood vessels and travel to other organs, invasion. Some genes allow the tumor to upregulate certain receptors so that it can use the body's own hormones like estrogen as fuel to grow. And then certain reference genes. And what this assay does is so it's ordered on the patient's tumor, not on the patient. So the patient comes to the clinic, we see them, and then we fill a requisition. So the pathologist from the hospital sends this out to a central lab. And then we get a report back. The report has a risk score on it, and it's divided into 3 risk categories: low, intermediate, and high, and depending upon that, we make medical decisions. The second assay, called MammaPrint, which was 70 genes, is also sent similarly. We see the patient, we call the pathologist, send in an order, the tissue is sent to a lab, and we get certain information, whether the patient is high risk or low risk. This is a binary assay, yes or no, high or low, and then what their estrogen receptor status and all of those other things are. The third one we talked about, Prosigna, is also an assay that this is actually performed in a lab, and this has actually 2 different components. It can be used in patients that are lymph node negative, where it can divide the risk of recurrence score into 3 categories, low, intermediate, and high. And in patients up to 3 lymph nodes, where it just divides into 2 categories, high or low risk. And as you can see, these are just, I borrowed these graphs from 2 different trials that this was used at. There is a difference in outcomes. What those graphs you see are survival lines, and there is a difference in survival. So it is actually a gene signature assay that allows us to prognosticate. Then what about patients who unfortunately don't have early stage disease, are diagnosed with stage 4 disease at presentation, or will have the disease come back? Even in those, we today have tools available that allow us to profile the tumor. And how I explain it to my patients is I say, you know what? The fact that you've been diagnosed with breast cancer or metastatic breast cancer tells me that we have caught a bad guy. How bad is this bad guy? Police does this work all day long. They fingerprint them, they take a DNA sample and can figure out what the rap sheet of that bad person is. Similarly, today, what we want to know is this not how your cancer looks under the microscope, but what kind of genes, proteins, and other biomarkers, this is the kind of genetic term used, biomarkers it expresses. So for stage 4 breast cancers, there's a platform that we use called Caris Molecular Intelligence. We've been using it since 2009. And it does help us figure out what's driving a patient's tumor. It helps us guide patients towards clinical trials if we find that there is a certain biomarker that they're driving. There's another assay that we use. It's called Foundation Medicine. This is just a sample of how the report looks. Again, using modern current technology called NGS, next generation sequencing, we're able to figure out the overexpression, underexpression of these genes, proteins, and other cell surface markers. It's not just, we are also participating actually at the Breast Center of Excellence in multiple clinical trials. Many of these platforms are available. Like I said, in the early stage disease, we have a pretty good idea of how we are using them, but we want to keep on expanding the patient population where we can use them. You saw my summary slide where I said, certain early stage patients qualify for these assays, not all. But can we start using them in more patients? So this is a slide that just shows one clinical trial that's available for accrual at our center, the RxPonder trial that's trying to use one of the assays called Oncotype DX in lymph node positive patients, seeing are there some patients who have lymph node positivity and would they really benefit from chemotherapy? Can we minimize toxicity, enhance their survival? This is another trial that is not available at the center, but we collaboratively work with center where it is available at UCSF, called the I-SPY2 study. Again, a Herculean effort at looking at using these assays in such a fashion that our patients can derive benefit today, not in 3 years, not in 5 years, by which time the data matures. Chemotherapy is what I do for a living. That's what patients end up seeing me for. So I just wanted to kind of give you an overview of what chemotherapy looks like. You'll hear these words a lot. The most common type of chemotherapy used in patients with breast cancer is adjuvant therapy, meaning in addition to. Patient's been diagnosed early stage, surgeon has done the surgery, the tumor is out, and then folks like myself and Dr. Patel come in to offer adjuvant therapy in addition to. The goal being reducing the risk of the cancer coming back. The weed is gone, but now we need to spray some Roundup so that the weed doesn't come back. Neoadjuvant chemotherapy, that's increasingly being used now, especially with the availability of some targeted agents. This is done before surgery. The tumor is large, the lymph nodes are positive. We need to give treatment beforehand, before the patient goes for surgery. Then the third type of chemotherapy we do is palliative chemotherapy. Unfortunately, patients who have had stage 4 disease are incurable, but we are giving them treatments to reduce their symptoms from cancer, and prolong their survival. And this is, again, some concept that's sometimes hard to understand. Many patients will say, you're telling me that you're going to give me a poison to make me feel better? And I said, yeah. I mean, there are symptoms from cancer that chemotherapy will take care of. Certain updates, we talked about one size doesn't fit all. There are much more modern agents. There are many side effects. There are many myths. Actually, just in this month's Bay Area News Group newspaper, there was a supplement that we talked about the common myths associated with chemotherapy. Some of those myths were not myths only a few years ago when chemotherapy was quite harsh and hard on the body. But with modern regimens, modern ways of giving them and supporting patients through them, we've been able to change the patient experience. Hormone therapy was actually the first form of targeted therapy available for breast cancer patients. Breast cancer is about 15 to 20 years ahead of other cancers in terms of personalized therapy. Knowing that patient's tumor is driven by estrogen, it uses estrogen as a fuel to grow, we can give anti-estrogen therapies to block those tumors. In spite of all of this personalization and modernization, what cancer researchers and doctors have felt is sort of a therapeutic glass ceiling. We did so good, so many new agents, so many new ways of giving them, a better understanding of how to give them, but yet the survivals were sort of hitting a glass ceiling. So clearly new approaches were needed. A lot of focus has been on prevention, early detection. You just heard about that. If you can catch it early, why even bother with this? Novel treatments, and most importantly, understanding the cancer biology. Why? Because this is how one cancer cell looks like. It's not how we traditionally see, one cell with cytoplasm nucleus. This is what a cancer cell looks like to most of us who are in the field of cancer. It utilizes anywhere between 300 to 500 different pathways just in that one cell to do things to the patients, right? Grow, divide, multiply, escape detection, travel, beat chemotherapy drugs, or be unresponsive to drugs, or even some cells may die, hide, and come back at a later date. So understanding these molecular mechanisms is what has allowed us to now come up with some newer treatments, very similar to the smart weapons we have. Since the first Gulf War, everybody is familiar with these. I mean, I have some of the most common ones up there. I'm sure everybody in this room knows about this. We see this on TV all day long. It's a similar revolution in breast cancer treatment that we are seeing today, where we are able to come up with what we call smart or targeted drugs. This is just a sampling of some of the ones that we use currently. Trastuzumab or Herceptin is a monoclonal antibody. Perjeta is another monoclonal antibody targeting the similar receptor, and then Kadcyla is yet another drug-antibody conjugate that you see on the slide there. More targeted, more selective in its action, more effective in its delivery. This is just one of the slides that shows a mechanism of how the drugs bind to receptors on top of the cell, get internalized into the cell, and then tell the software in the cell, that's the DNA, that's the software that guides these cells into starting to die or not survive or not escape detection. Chemotherapy, targeted therapy is, what I tell my patients is mostly considered the sexy part of the world, of the cancer world, right? Discoveries. But, I personally believe that just managing patients through chemotherapy is equally important. It's the equally sexier part of our job. And I explain it to my patients. I say, hey, chemotherapy is chemotherapy. Biologic therapy is biologic therapy, made by the same manufacturers, delivered in the same standardized fashion. But it's the way you're shepherded through that experience that makes a difference in a not so good outcome and a good outcome, very similar to an example being your favorite steak place. Steak is a steak, piece of meat. But the way it's delivered and prepared is what makes the difference. So similarly, we believe at our cancer center of just sort of enrolling patients in a very comprehensive symptom management program. Some of my patients are here in the audience, and they can tell you how much bored they get of seeing me and seeing our nurses and being questioned and being talked about. Why? Because we want to be on top of every symptom. We don't want to dose reduce our treatments if we don't have to. We don't want to delay our treatments if we don't have to. So with aggressive symptom management, we can shepherd them through there. The goal being, this is where we are getting to, right? Understanding the tumor at a molecular level, understanding the patient at a chemical level. We are all same, yet, genetically we all might be similar, but chemically we are all unique. Can we understand the patient biology a little bit better? Can we understand who will benefit and who won't benefit? Can we risk stratify better using these tools so that we can come to a day where we are truly delivering personalized cancer care? Some of that care, like I said, is already available. So here in your community is the Breast Center of Excellence. We are accredited by the National Accreditation Program for Breast Centers. This is not a lightweight designation. We achieved that designation in 2011 because of a concerted effort of many people in this room today, with the goal, as Dr. Patel mentioned, of providing comprehensive, compassionate, and personalized cancer care. It's great. We have speakers here. We have a great venue, and we are all very eloquent speakers, but you don't have to take us on our word. This is our statistics of patients treated here at the center. There are certain metrics that national bodies use to figure out whether a program is worthy of this recognition. This is one. How many patients seen at your place get breast-conserving surgery? The benchmark is half of the patients should be getting this. For our center, 91%. How many patients did have radiation therapy or adjuvant radiation therapy administered within 1 year? Nationally, only 85%. In California, only 82%. At our center, proudly 100%. Thank you, Dr. Patel. Combination chemotherapy is considered or administered within 4 months. And now these are not statistics or sort of things that we have made up. This is what the national bodies look at. How many patients had combination chemotherapy considered or administered? Nationally, 82% of eligible patients ever got these treatments. In California, 78%. At our center, 100%. What has all of this translated to? More survivors. Today in our country, there are 20 million people who have either beat cancer or are living actively with cancer. That's a huge number that we are dealing with. So we have gone, with this personalized mantra a little further now. It's not enough just to personalize your diagnosis, personalize your treatment. Let's personalize how you get back to life, how you not just survive but thrive. So that's why we participate in a survivorship clinic, create a surveillance plan for our patients, assess them for toxicity and intervention. Cancer prevention, many of our patients have already dodged the bullet. Do they really want cancer coming back? And then coordination of resources. There's a cancer wellness and survivorship program, lymphedema therapy. You saw all those tables out there today. A separate cancer nutrition program. We are proud to be one of the only few STAR cancer rehab certified programs in the country now. So that was a Herculean effort that concluded. You can learn more about that out there. And then finally launching into, it's not just about treatments. Treatments or cancer therapy, radiation, chemotherapy, biologic therapy in our minds, in all the doctors that practice at this center, is only 50%. The rest 50% is mind, body, and spirit. So that's why there's a full integrative oncology program. There are foundations here today who will be talking about how they support our patients in that. So it's kind of bringing this whole package and personalizing because various other resources that you can see up here, many of the, our partners who are involved with these resources are out there, because this is our goal. For most patients, this is one of the most challenging times of their life, if not the most challenging time. Our goal is no, survival alone is not enough. We want you to get to thrive. So, anybody here interested in skydiving should look me up after this. Thank you very much.
Fantastic. Thank you, Dr. Sawhney. That was terrific. Well, what we're going to do now is actually take a moment. I do want to get back to this point of the national accreditation. So we've been doing this for quite some time, as you know, in terms of symposia, and our program has grown. And part of it has been the rigor of this national accreditation that Dr. Sawhney mentioned to you. It's really a Herculean task. It takes excellence, it takes technology, it takes leading edge, it takes state-of-the-art, state-of-the-science, it takes collaboration of many entities, not only on providing care, diagnosing disease, but also administration. And I just want to mention a few of those now that have really allowed us and paved the path for us to be here today. And that starts with the leadership of ValleyCare Hospital. The whole health system has really been a terrific forward-thinking partner for us, physicians wanting to embrace this and put the resources behind it. It's led by Corey Watson. If you could please stand as I mention your name, hold your applause to the end. Corey Watson is the Director of Diagnostic Imaging, Cardiology, and Cancer Services. Standing there. Denise Estrada is a manager now of the Cancer Services, but really truly plays multiple hats for us. She navigates patients, she's been part of our resource library, but now she's the manager of the Cancer Services. Lee Teckel, please stand. She's part of our clinical research coordinator. In community practice, we have one of the few centers that every patient that comes in, a new patient that comes into our center, gets screened for potential clinical trials before they're even seen by a physician. And Lee, along with Denise and others, are really a key component there. That way, as soon as we see the patients, we're already thinking about, how do we address the various aspects that are necessary for good outcomes. Sherry LaSalle, a breast nurse navigator. Please stand, Sherry. Sherry is the one who really, it's true, she does navigate from start to finish the patient experience, guiding through all these challenges about the diagnosis, and then all of the patient visits, and then survivorship. Angela Byers and Jessica Wong are key components and leaders of the STAR rehabilitation program for us. Again, we have a very active rehabilitation program, lymphedema massage therapy, recuperation, evaluation, and management. We're very proactive on that. And if I can have a round of applause for all these people now, that would be fantastic. Thank you very much. And as Dr. Sawhney mentioned, this has really grown over the years. We started out in the cancer center upstairs with 15 to 20 people that would come for the free crackers and apple juice about 5 years ago, to being at FAS, where we started having some support from our community. And it's amazing when we see people in the cancer center not even realizing all the terrific efforts that are happening right here at home. And from there, it's grown, and we've been here in the Palm Event Center, and we have terrific supporters who hopefully you've spent some time with, and we're going to hear a little bit more about today. And again, additional volunteers that have been instrumental in putting this evening together for us, including, please stand, Dina Pan, Kristen Litz, Cherie Birch, and Cheryl Villarreal. Please stand. Thank you. Okay, we're going to keep the agenda going, and this is where you've heard from our leaders, you've heard from our experts, and about the state of the art, the state of the science, and we're going to shift gears here. And as I started here, a lot of my enjoyment coming from a university setting, academic setting, to a community-based academic setting, is I get to work with people like Dr. Sawhney, Dr. Chang, and many other of our breast cancer physicians, and we really believe that you treat people, not treat cancers. And you're going to hear now from one of our patients who has a remarkable story of courage. It's inspiring, it's humbling, and I don't want to give her a long introduction because I want her to really share her personal experience. But she truly represents a survivor. She's living with metastatic breast cancer. As Dr. Sawhney pointed out, it's not just about surviving. I wasn't talking about the mic when I was talking about the survival, but I appreciate it. I know. It's not just about surviving, it's about thriving. And it's living, you can do that when you're living with metastatic breast cancer, and she's going to teach us that. Her name is Lorna Belluomi, and Stacy, who's a physician assistant at the Cancer Center, promised me, and in her phone, she has the phonetic spelling of Lorna's name to make sure it's Belluomi. And so, Lorna, please join us. Please talk about your journey. We're so happy to have you here today.
Thank you. Thank you. Thank you. And good evening. Unlike some of the other speakers, I didn't go to school to study oncology, but I do have experience on the subject. I was diagnosed with breast cancer in 1996. And since then, I've had 13 surgeries, which include several biopsies, a mastectomy, several for reconstruction, 2 to place ports, and a procedure called radiation frequency ablation performed on my liver. I've also had 7 CT scans, 34 PET CT scans, and 1 breast MRI, which I shook throughout, resulting in an unreadable and useless report. I've had 2 needle biopsies in my liver and 1 under my arm. I went through 4 weeks of hyperbaric treatments, breathing in pure oxygen to heal wounds which would not heal on their own. I've had 6 weeks of radiation, times 2, 6 forms of chemotherapy, and testing for the breast cancer gene. Not surprisingly, I test positive. In preparation for this evening, I listed and counted these procedures, and even though I lived through it, I was really surprised. I knew the numbers would be great, but I had to ask myself, why do I feel so fortunate and grateful? How is it that I love my life so much? And what keeps me hopeful and smiling? Now, if this sounds a little too rose-colored to you, I'll also tell you it hasn't been an easy road. 18 years of roller coaster moments and lessons all strung together have helped me to learn and endure this disease. Like the moment I learned to let my husband take care of me, I married for the first time and I was in my 40s. I always considered myself strong and independent, but when I met Alan, I had already had stage 4 cancer for a couple of years. But it was what I called in the quiet years, when it lay dormant in my liver. It was just after we married that things started up again. I wasn't used to Alan or anyone else taking care of me, so I went along business as usual, going to my appointments all by myself and telling him not to worry, I can go alone. I shared what was going on, but I tried to protect him, just like I'd always done before. I pulled it off for a couple of years, but eventually up and down tumor markers, drugs testing and not working, looking into clinical trials and dealing with the insurance were all taking a toll. There comes a time when you need to ask for help. Most people do so at the get-go. They surround themselves with friends and families who want to be there with them. Not me. It's like when I went snowboarding for the first time. Alan and I had only been dating for a couple of months. He showed me how to balance my weight as I went down the hill, like in an S-curve, and he showed me how to kind of turn and kick up the snow. But when he tried to get me to wear the wrist guards, I said, no way, I don't need them. The second day we went up we went higher on the mountain, and I knew I was over my head, but I shut him out again. I can do it myself, I told him, as I also tried to convince myself. And I did it for a while. But as the day went on, I grew tired, and while trying to avoid knocking into another novice skier, I fell, and I fell hard. Right on my wrist, broke it in 2 places. Laying face down in the snow, I felt a little foolish and helpless, but Alan was there to pick me up, follow behind the ski patrol as we went down the mountain, and sit next to me before surgery that night. He also helped to clean myself up after I threw up in the gutter from the anesthesia, but he's a fireman, so he's used to these situations. When I finally grew tired of taking care of cancer by myself, I fell down again. This time, it was in the bathroom. I crouched on the floor at Alan's feet and released long-held tears. I pleaded with him for his help. Again, he was there to pick me up. He's always been there. If only I'd let myself fall sooner. In my cancer journey, there have been many lessons from friends. In 1999, I joined a support group. For me, it was a safe environment to share with other people who were going through the same things that I was going through. But support groups aren't meant to be a substitute for the people who are already in your life who want to be there for you. It didn't occur to me that I put all my fears and vulnerability into one support group basket. I didn't share with anyone else. One friend took this very personally. She felt left out, hurt, and eventually turned away. Now, of course, I had a lot on my plate at the time, and this wasn't a time for self-evaluation. But thinking back on it now, I realize my friends want more than anything to help me. Maybe some even need to help me as a way to get themselves through it. Fortunately, I now understand the value of letting down my guard and trusting. It's like a physical weight is lifted when you share your fears with someone. Now, I'm not saying to go off and tell anybody. That's just a little crazy. And besides, the woman next to you on BART may not want to hear it. But you know the ones. They're the ones who are there and have your back. They're in your life for a reason, to be a part of it, the good and the bad. I have some really good friends. Some of them, many of them are here tonight. They often check in with me. Lorna, don't you have chemo this week? When's your next PET scan? How are you doing? I love that they manage to keep track of my schedule better than I do. But I want them to know I have their backs too. I need to live outside of my own life. I don't always want it to be about the cancer, especially since it's always there. And let's not compare problems. If it's important to you, it's important to me. This isn't about deflecting attention off me. Hey, I can bring up the big C anytime if I want that. So I have some advice for family and friends. When someone has just learned they have cancer, I find that some just want to talk and some cry. So my suggestion, first listen. And if you feel it, cry with them. A hug is always good. It's a universal way of saying, I'm sorry, I wish you didn't have to go through this. And when it's time to say something but you don't know what to say, be honest and say that. Or tell them that you love them and that you'll be there and go through it together. Now, on the subject of chemo, even if you haven't experienced chemo firsthand, you probably know someone who has and have an idea of what the side effects are. With this in mind, unless there's some real positive value in it, let's not share the ugly experience our Aunt Betty, coworker, or family or friends had. Leave the unpleasant stuff to the doctors. They're good at it, and if it's necessary, they'll cover it, and probably provide a pill or some concoction to help them get through. If someone asks me what to expect, I may say any of the following. You're going to lose your hair? I'm sorry. Well, get a cute wig before you lose it, and some nice scarves and a hat to cover yourself at night, because it gets cold at night. Bring a friend if you can for a second opinion, and this may not be the time to try some funky hairstyle or some cute little hair color that you've never tried before. Leave that for the second wig. And when your hair grows back, you might find you like it short. Let others take care of you. Keep looking forward, focusing beyond the treatments. Find your sense of humor. I know. How can you be laughing right now? But your first line of defense is your mind and your attitude. I truly believe it makes a difference. So try to see the humor in stuff around you. You may not have to look very far. People do some silly things all the time. Blame lots of memory, emotional control, and just about everything on chemo brain. And you can use this for up to a year after you finish treatment. And finally, as far as I'm concerned, during your treatment, you get to do whatever you want or feel like, within reason, and sometimes you have to check with your doctor. About 5 years ago, my husband and I and two other couples were planning a trip to Europe. Just before leaving, I found out I was going to have to start a new chemo and I was going to lose my hair. Rather than leave pieces of it throughout Europe, I decided to shave my head, start wearing the wig right off, hoping I could keep this a secret from the other tour folks. A week into the trip, we were in Barcelona, Spain, with our tour group of 20 or more. We had dinner and went to see professional tango dancers. After the show, my friends walked out onto Las Ramblas. It's a busy sidewalk in what is a considerably very lively downtown. We began taking photos of each other being romantic and kissing while waiting for the rest of our tour group to exit and head for the bus. Alan and I stepped out for our turn. We held each other while our friends' cameras clicked. Then Alan decided to flip me back in one of those dance dip moves. He held me at the waist with one hand and supported the back of my head with the other. I held onto him and threw one arm up behind me. But our timing was off, because when I moved back up, Alan stayed down, and he still had the wig in his hand. The next thing you know, the wig's on the ground. We tried as fast as we could to get that wig back on my head, but it was too late. Some of the people from our tour found out my secret. I was embarrassed and devastated. I told Alan to tell my friends to delete all of those photos from their cameras. Then I went to our room where I cried. I couldn't imagine ever getting over it. That night, Alan held me until I cried myself to sleep, and he kept holding me all night in the sweetest and most tender way. I don't know who saw the incident, but I'm certain the story spread over breakfast. I got on the bus and made sure not to make eye contact with anyone. It wasn't long before two older women who sat in the back said, "Every day we just kept saying to each other, 'What beautiful hair you have. Always looks so perfect. Too bad it's a wig.'" Well, sometimes the obvious is just what you need to hear. It opened the doors for others to share their cancer stories. And no matter where you are around the world, with different accents and lifestyles, you're not alone in this disease. Isn't life like that? Awful things happen, and then your wig flies off on a busy sidewalk, and you're left with a tender memory and a party story to share. For those of us who have lived with cancer for a long while, I like to think we are the elite of survivors. We do our best to go with the ups and downs. We are experts at navigating our busy lives through appointments and new drugs which come with new side effects. We're pros at making use of our time while waiting to get an appointment, waiting for a test result, waiting for what to do next, and just waiting in waiting rooms. Like all cancer patients, our lives include a circle of additional team members who help us along because fighting cancer is like a sport, and we're only as good as our team. These include the doctors, their medical assistants, nurses, technicians, and office staff. They all play an important role, and they do it with a smile. For the most part, I have been fortunate to have good experiences, but there was a time when I was not getting what I needed from one of my team members. We weren't communicating well, and his silence in answer to my tears made me think I was a lost case. Sometimes it's time for a change. That's when I was introduced to Dr. Sawhney and Stacy Laster, two members for the price of one. Dr. Sawhney was the one who explained to me that while we would manage the cancer as best we could, I needed to learn to live my life outside of the medical appointments. We may take part in clinical trials which can not only extend the lives of others, or extend our lives, they may also help those who follow in our footsteps. But we are more than this disease. We are people who can thrive when we live as best as we can. I have a lot of interests. I like to volunteer at church, work out, meet friends, go to the movies, play golf, travel, and take daily naps. Sometimes I'm not feeling so well, so when I don't have the energy, I just do less stuff, except for the naps, and that's okay. Finally, the most important relationship is the one I have with God. A woman once told me, eventually everyone has their come to Jesus moment. Well, I was brought up with God, and since living with the cancer, I feel closer to him. Early on, I prayed for healing and strength. He got me through it, but I still held my hands tight to control and fix the situation. Through the years, I've learned to surrender the cancer to God, and in doing so, I'm left with peace. It is comforting to know that my friends and family pray for me too. In fact, I think there's a whole church full of prayers. It's not that I'm any more special than anyone else, it's just what the church does. Look, I may not always get the results that I like, but I know God has my back. He will help me down that mountain, help keep the wig on straight, and be there when I need him. I do love my life. I'm fortunate and grateful for my family, friends, and my team, but it is Christ that keeps me hopeful. So, if you see me around and I'm smiling, it's his light shining through. I'd like to end with a verse from the Bible. It comes from the book of Romans, chapter 12, verse 12. Be joyful in hope, patient in affliction, and faithful in prayer. God bless and keep you all healthy. Thank you. Thank you.
I think I speak on behalf of all of us, Lorna. Thank you for sharing that terrific story and your experience with all of us. Well, we're going to go right into a couple of our key sponsors here this evening. And the first one is Barbara Roudebush. She's from the Tri-Valley Socks and Bras for the Cause. Those of you, she's going to talk about their initiatives. And it's a really fun experience if you ever participate in any of these. I know Dr. Sawhney has. We have some terrific pictures of him with his bra on. Barbara has been actively involved in the Bras for the Cause breast cancer walk since its inception. She's a two-time past president and board member for more than 8 years for Tri-Valley Socks. We have such a terrific collaboration with them and the ValleyCare Health System in our breast cancer program specifically. And they've been terrific supporters for us to be able to put symposia like this. So, Barbara?
Thank you for giving us this opportunity. This is very cool. I was pretty sure I'd be the only speaker wearing a tiara. And you may be asking yourself why. And our Bras for the Cause breast cancer walk is always the Saturday of Mother's Day weekend. And this next event is going to be our 10th anniversary. So we got online to look up what, suggested gifts are for a 10th anniversary. And for some reason, every woman on the board chose diamonds over tin or aluminum. So that has become sort of the theme for our walk in 2015. I can talk about Bras for the Cause and Tri-Valley Socks for hours, but in going to stick to my promise of 5-ish minutes. So I'm going to try something here, trying to communicate the spirit of the event, some key information to you. And I'm going to play a slideshow here with pictures from our past walks. And I'm going to do this while I'm speaking, so hopefully this sensory overload here might do a couple of things. One, keep you entertained. 2, give you the spirit of the event, and 3, if I screw up, you may not notice as much. So, where am I at here? So, Tri-Valley Socks. When I think of Tri-Valley Socks, there is this quote from Margaret Mead that goes something like, "Don't ever doubt that a small group of thoughtful and committed citizens can't change the world, because indeed it's the only thing that ever has." And that makes me think of Tri-Valley Socks. We started out as nothing but a walking team, training for marathon breast cancer walks. And that kind of brought us together with one common goal, or common commitment, We basically think cancer sucks and we wanted to do something about it. So we started off, with the training walks, the walking, the talking, the fundraising for that event. And one thing led to another, and it culminated in us getting organized and becoming an official nonprofit organization. We tried several fundraising ideas and finally ended up with a smaller version of a marathon walk that we could manage ourselves, do it locally, and kind of put our own little twist to it. We learned, we figured we had enough experience, we could pull this off, but we also learned that you always can learn. So Bras for the Cause was born. How many of you have participated in the event as a walker or a volunteer? Great. Thank you very much. We created and organized the Bras for the Cause walk, but really I think of it more as a conduit. It's a conduit for that thoughtful and committed group of people who want to do whatever they can or whatever they're able to help fight cancer. So it's a unique event in several ways, and I'm going to talk about some of them. And for those of you who have participated before, maybe it will give you a little insight into why we have organized it the way that we have. So most obvious is the decorated bras. I still marvel at the amazing feat of salesmanship that convinced the city of Pleasanton to let us have hundreds of people walk around in their underwear. We figured cancer has caused enough tears, it's important to carve out some time to have some fun. And really, it turns out decorating the bras is as much fun as wearing them. I think I have one for every holiday now, and I'm proud to say only one of them have I accidentally glued to the bottom of my wine glass. It's unique because from our event, 100% or more of the money that the walkers raise goes straight to the beneficiaries. We are out to have a good time, which you can see behind me, but we are very serious about raising the money. Every walker who signs up agrees to raise a minimum of $200 in tax-deductible donations, and that scares a lot of people, frankly. And I think of two things when I hear about that. Number one, it's not nearly as scary as when they walk into the room and tell you you have breast cancer. And number two, don't sell yourself or your friends short. It's not that difficult to raise the money. And I heard a quote once that says, if you think you're too small to have an impact, you've never been to bed with a mosquito. Most of the money that is brought in is made up of checks of $25 or less. So it's a small impact, but when you combine that, it's huge. And I mean, most of our walkers do it in one email blast. I mean, come on, you're walking around Pleasanton in your underwear. Who's not going to pay to see that, right? So our website has a lot of tools that help make that fundraising even easier. And bottom line, once you try, you get there. It's not difficult. So how do we pass on more than what the walkers raised? Two reasons. One is Tri-Valley Sox, we are all volunteer. We have absolutely no overhead except the cost to put on the event. And the main reason is because of the generosity of what we call event partners. These are the corporations and the businesses that donate the money to help us put on the event. And whatever they donate that we do not need, that covers or more than covers the cost of the event, that is also passed on to our beneficiaries. So everything that is raised in that event goes on. 9 years ago when we first started this, it was one of the first evening events that was held. And there's something, to us anyway, that is special and symbolic about starting to walk in the daylight, walking into the dark, and then coming into a party at the end of it. For some people, that party is a little bittersweet, thinking about those that we have lost. For some of us, we're just happy to be there at a party. And for other people, it's like, hey, I just finished a 10K. I earned the right to eat that cookie that's the size of my head. So that first year, the signage for the evening wasn't all that great. We only lost one walker, and fortunately, we found him quickly because it was my husband. And he was the caboose. We always have a person who is walking behind the last walker. Nobody walks alone in our events. just like nobody should be fighting cancer by themselves. So we want to make sure we have a lot of support for everybody that's out there. We've never lost anybody since there, so rest assured, but that is why we have moved to marking the route with fluorescent pink flagging tape. I think last year I calculated it out, and for every foot of that 10K 6.2 mile walk, we had a foot of flagging tape. So Pleasanton looks particularly lovely that night. So we have, it is a 10K walk. It's not a run, it is a walk. It is a challenge by design. It kind of symbolizes the challenge that every person who faces cancer goes through, and every person who cares for or loves a person who's going through it experiences as well. And the support is important to us. We provide a lot of support. Someone starts and can't finish, we have a sweep vehicle, and it's not just any vehicle. It is a limo, because we think everybody who participates in that event is special and they deserve to be spoiled. So between the limo, we have a finishers party with awesome food, and we have goodie bags that are probably contain a value that's bigger than what anybody would have paid to register for the event. We do limit the number of our beneficiaries. We like to take all of those little $20 checks or less and combine them in a way that we can have a real impact and really affect a change to our world and make it better. So these beneficiaries all have to be qualified nonprofit organizations, and they must focus on research, education, and treatment of breast cancer. So our beneficiaries from last year's walk were Hearst Foundation, yay Vera, wherever you are. We're very happy to support events like this, which are huge in educating people about breast cancer. Access Community Health to help those low-income women who need the support, as well as UCSF Comprehensive Cancer Center. And each year we revisit those beneficiaries to make sure that we are on track and taking good care of those funds that we raise. So how have we done in the last couple of years? Last year we hit 3 huge milestones for us. We had the largest number of walkers, 525 walkers participated in the event. It was the largest single amount that we raised in a year. More than $175,000 was raised. And I keep saying, you know, we did it, but the we is not just Tri-Valley Sox. We is Tri-Valley Sox, the walkers, all of those people who gave those, you know, $20 checks to people. It's the volunteers who make that event safe and fun, and it's our event partners who help us cover the costs and also just make it a very exciting event. And the third thing was that $175,000 took us to a goal. Well, actually, it pushed us past a goal. So in 9 years of the event, in total, more than $1 million has been raised. So applaud yourselves, because you did it, Tri-Valley. So I'm going to wrap this up here pretty quickly. On behalf of Tri-Valley Sox, I would like to invite all of you to come out and participate in the event in 2015. You have information in your goodie bags about the event and how to find us. And come out with us and prove that we all can make an impact in our world and make it better and have fun while we're doing it. And you don't have to wear a tiara if you choose not to. Thank you.
Thank you very much, Barbara. For those of you that have not attended, it's certainly a highlight of many of the fundraising activities that we do, so I encourage you to try to attend one of those. Well, the next speaker also is a great supporter of our community. Dr. Vera Packard is the executive director of the HERS Breast Cancer Foundation. She's originally from Brazil, where she earned her medical degree, and she specializes in breast disease, in particular breast cancer, and has worked both in university and private practice for over 20 years. She has a deep commitment to women's health issues, which inspired her to found a nonprofit organization devoted to breast cancer in 1997. She truly believes in communities coming together to help each other, and she's been, in fact, the president of a former Rotary Club in Brazil, She was recently awarded one of the 100 Women of Influence by Silicon Valley Business Journal, an Outstanding Businesswoman by ABWA, which is American Business Women's Association, by the Bay Area Council. So we're happy to have her here to talk about her initiatives and support us at the symposium this year. Dr. Packard?
Good evening, everyone, and it's very humbling to be speaking after amazing doctors. And Lorna, where are you? Thanks for your story. And you know, literally, who cares about that wig? You're beautiful. Thank you so much. That was heartfelt. Thank you. And Tri-Valley Sox, I can't thank you enough. I don't know what to say. Thank you, thank you, thank you, thank you. And of course, later you're going to hear Sandra, which is a hero. So I'm just very humbled to just be here, say a few words on behalf of the HERS Breast Cancer Foundation. And we like to call ourselves, so we are a soft place to fall. And I think I get the right one, yeah. Are you Pinktober? And I don't know how to pronounce that, but it's Pink and October all together. And I just found I was playing around, putting some things together. And I love to see, I'm from Brazil, like Dr. Patel said. I love to see the Christ in pink, and then Sydney, and the Empire State, and the Eiffel Tower. So the world is getting pink, at least in October, which is pretty fun. But we all know that breast cancer doesn't happen only in October. And we can't think about it in only October, but it's really special. And I think I got the knowledge that it was the wife of Henry Ford, if I'm not wrong, that started the breast cancer October month. So America starts this. And I became an American citizen in 2008. And I have to say that I'm very proud of being part of this country. And just think about other countries, and countries like Brazil. We are in kindergarten, maybe in elementary school when it comes to the nonprofit world and the amazing work that's done in this country. I say that America, when it comes to the nonprofit world, has a PhD, because it's amazing what the American citizens give in time, talent, and money to the nonprofit organizations in this country, especially in California. So I'm very honored to be part of this country and to be, having been able to say that I have two countries. It's pretty amazing. But the HERS Breast Cancer Foundation, so HERS was a nonprofit organization, and HERS stands for hope, empowerment, renew, and support. And as a former breast cancer surgeon, I haven't practiced for 11 years. So thanks for the education, Dr. Sawhney, for all the new things that's happened. It's like, oh, I didn't know all that. So it's good to know, but I've been out of the field for 11 years, been a director for this organization now for 6. But that's all my patients were looking for: hope for a better life, empowered to live it well, renew their spirit so they continue to do it, and support from family and friends and organization. That's what we try to do at the HERS Breast Cancer Foundation. And we help the patient in a very unique way by helping them with their post-surgical garments and products. And we do that even regard of their financial status. So we help people have insurance, but we also help the underserved, and we're very proud of that. It's kind of like taking care of the aftermath. It's been a surgeon myself, and it's very interesting when I'm sometimes in cocktail parties or something, and people ask, what I do, and I say, I run a nonprofit organization for breast cancer survivors. We provide the bras and prostheses, and people, I'm going to get a glass of wine. Because it's not as fancy as research or mammogram or early diagnosis, which is very, very important. But I'm a woman, and I can tell that the aftermath, and sometimes that not so good mercy of the mirror with the deformities that our bodies can be caused by the treatment makes a difference. So I'm very proud of what we do. And my daughter likes to say we moved here, she was only 9 years old, so with English, something's been funny. So she said, Mom, why do we say prettier and more beautiful? Why not beautifuler? So I like to say that we like to help women to become beautifuler after the diagnosis of breast cancer with our products. And we have 4 programs, and we have what we call Bras for Body and Soul. the program that we provide the bras and prostheses for the women who have insurance. And then we support You Survive, which is the program. We provide the same service, the same kind of bras, same materials, same products for the women who can't afford those products. I mean, a prosthesis can run to $360, so it's pretty pricey when you have other things to pay. The lymphedema projects, this program that we're very proud of, because a lot of insurance, including Medicare, they don't cover the lymphedema garments, and they can become heavy and pricey as well. And we get grants, thanks Tri-Valley Socks. I have to say that, Barbara, where are you? Love you. Thank you. And but all of these programs, with help with organizations like Tri-Valley Socks and other things that we do, allows us to give these products to the patients. And also the Hair with Care. We like this cute name for providing the wigs. You know, like you, Lorna, you didn't need, but Hair with Care, that's what we call. And we serve over 1,200 clients a year. And we are increasing our capabilities because we have 2 locations now. Very happy this year has been a very exciting year for us. We used to have we've been around for 16 years. We used to have our location only inside the Washington Hospital in Fremont, which is this, so you can see what we do there and make our fitting rooms like really a place that it's a place for talking, helping you, listen to you, and take care of you. And now in February this year, we open our facility at Stanford Cancer Center. So we'll probably, be growing this number of 1,200 patients a year. So we're very proud of being on that other side of the bay, but we just would like to be in more places so the woman doesn't need to travel to get these kind of services, and that's our main goal. We have 4 certified breast care specialists. These ladies have to be trained to serve you as a patient. It's not just, I'm going to get a bra and you get, oh, here's your bra. It doesn't work that way. You get to be fitted and really something that works for you after the different kind of treatments, from lumpectomy to reconstructions that sometimes are great. And I love plastic surgeons, believe me. But sometimes the results are not what you expected, and that's what these products do. I remember once one of our patients saying that it made me feel like a lady again, and I can hold my head up because I feel whole. And we hear this and really warms our hearts. We have 2 cosmetologists that also help with the wigs. We have a total of 10 employees. We have 8 board members. We have our board chair here in the back. Mr. Mike Engel is over here with us. And we have weekly volunteers besides the other volunteers that we have in our event. So here's some, we had Pam Condi here with us today. She just had to leave a little early. So we are the only nonprofit in the San Francisco Bay Area that provide the service that we do the way we do, being completely open, not only to help people with their insurance, take care of all their billing, and help the people that can't have the insurance. And we're working very hard, and as Mother Teresa said, we need money to make good in the world, but we're working very hard, and we're gonna make happen that we're gonna have our location also inside ValleyCare Health System. This is gonna make it happen, and I wanna thank you. And I wanna thank Dr. Sawhney, Dr. Patel, and the ladies, and everybody at ValleyCare, because it's been a goal of them to have us there. So I just want to thank everyone for having us and having me the opportunity to say a few words to you. But more than anything, I just want to thank you for giving me the opportunity to be among such amazing people and the stories. And God has just given me a second chance in my whole life, to being a surgeon once and now a director of a nonprofit organization. And like they said in Sound of Music, which was my favorite movie, I must have done something good in my childhood, but I don't know what it is, so I keep trying to do the good work so we can continue to help breast cancer survivors in the Bay Area. Thank you very much, and happy Pink October for all of you. Thank you.
Thank you very much. That was great. Well, we're gonna roll right into the keynote speaker, the last speaker, and I'm gonna introduce Sandra. You can make your way up here. Many of you know who she is, In 2008, Sandra, actually I'm going to start back. Sandra is a proud U.S. Army veteran and has a BS and MBA degree in business management. She's also certified as a project management professional and as a Lean Six Sigma Green Belt. Sandra works full-time as a project manager for Xerox in her free time. She is an active community member and volunteers in the Pleasanton Chamber of Commerce Foundation Board. She's an advisory board member for Hope Hospice, as well as a role of president and founder of the Sandra J. Wing Healing Therapies Foundation. The language of cancer is grim. You've heard a lot about it today. We talk about cytotoxic, we talk about things that address cancer cells throughout the body, chemotherapy, biologic therapy, radiation therapy, lumpectomy, mastectomy, bone marrow transplant, neuropathy, nausea, hair loss. But cancer survivor Sandra Wing has introduced a different vocabulary and vernacular for us as cancer patients and as providers. Acupuncture, acupressure, meditation, guided imagery, therapeutic massage. In 2008, she created the Sandra J. Wing Healing Therapies Foundation to help remove some of the financial burden so that a cancer patient can experience healing therapy comfort throughout his or her treatment. I had the privilege of serving on the board for just about 2.5 years, and it's remarkable as a healthcare provider talking about radiation therapy, chemotherapy, dosing, and being a part of the therapy. It actually comes relatively easy to us. But the privilege of being a part of people's lives, sharing stories like Lorna's, being associated with folks like Sandra is a gift, and one that keeps us coming to work and keeps our job in oncology very rewarding for Dr. Sawhney, Dr. Chang, and myself. Sandra is influential, she's charismatic, she's dedicated. The effort she leaves, in my opinion, makes having cancer just a little bit easier, and being a provider for cancer patients that much easier. She addresses quality of life, and she's going to talk about that, but she also importantly she makes us look good. She enables patients to go through and complete the care that we know about and want to provide to optimize her outcomes. She's a personal friend of mine and truly a local community hero. Sandra, come and tell us about your story.
Good evening, and thank you, Rakesh and Dr. Sawhney, and I'm just so proud to have an opportunity to speak at the 5th annual event tonight, so thank you. I'm going to talk about my personal cancer journey, where I started, and what transformed out of that to create the foundation that I'll tell you a little bit about. So one of the things that I was afraid of was needles. Never liked to be poked. And I was afraid of anesthesia because I was just worried about it. And so when I was told when I was 47 years old that I was going to have a hysterectomy, I was pretty scared because having a major surgery was very frightening. And it fears with all of us, start from something in your background probably. And mine was that 25 years earlier, my friend, her mother was the same age, 47, and had a standard hysterectomy, and she never came home. So I was very frightened of having a hysterectomy surgery, and she didn't come home because of the side effects of the anesthesia, and she went into a coma. And so my fears were pretty heavy. And I didn't know what to do. So my spouse and I, we contacted a friend of ours who was a radiation oncology nurse, lives in Virginia, and we said, you're also a holistic nurse. And do you know anybody out here? I'm going to have a hysterectomy surgery at UCSF. Do you know anybody out here that I could talk to because I'm really frightened? And it had nothing to do with having cancer. I was just frightened of the needles, frightened of the anesthesia. And she said, yes, I do. So she recommended me to somebody at UCSF who was an oncology nurse there, but she was also an acupressurist, a guided visual imagery specialist, and somebody that taught me to focus on my breath and to deep breathe and meditation. And so I went to her for 2 weeks before my surgery. And that was just incredible because it calmed me down because I was very nervous and very anxious about the surgery. It calmed me down so much that the day of surgery, I went to saw her for 1 hour before the surgery, and then I got poked and prodded with those IV tubes for pre-op, and I was calm, wasn't worried about it. I was miraculously calm because they had an emergency surgery, so while I was in pre-op, I was there for 5 hours until my surgery came up. So that's quite a long time to be in the position that you didn't want to be in. So I went to the surgery, came out, and all I really wanted was that same lady to come in the room the next morning, which she did, and gave me a massage and got me out of the bed and had me focusing on healing thoughts the entire time, those 2 weeks before, and was all focused on helping me think, healing thoughts coming out on the other end, taking away the nervousness and the fear that I had of the potential outcome. And the doctors and nurses at UCSF were kind of surprised that I didn't need as much drugs as are normally standardized for the outcome of that surgery. And I credit all of that to what I just said. Guided visual imagery, thinking positive thoughts, thinking healing thoughts, thinking of the outcome, and believing much more positively and focusing on that. Some of the visualizations that I had were things like this. This is golden healing rings around my body, like a slinky almost, right? Kind of circling your body. And I had different guided imageries, different thoughts. Some of them were me floating on water because I like Hawaii a lot, and having my dog on my stomach, and we were just floating, very calm. But the point is, that's what guided visual imagery does. It takes you into a different space, a different place, so that you're not so stressed out or anxious or thinking about the bad outcomes of a diagnosis. Anyway, that's when I got out of the surgery is when we learned that I had ovarian and uterine cancer. So, needless to say, I really stayed with guided visual imagery and these healing therapy massages. I was fortunate; they were caught at the early stage, but the cancer cells were aggressive for the ovarian. So they said we should have a full range of chemotherapy treatments. So that's what I did, and stayed with these healing therapies, these therapies that I never tried before until this experience. And these therapies not only help me as the person going through an unpredictable disease or problem or health issue, but they help the caregiver. They help beyond just that person trying these therapies. And what do I mean by that? My spouse, Gracie, was shown how to apply acupressure on me when I was really restless or anxious or couldn't sleep, because maybe it's the side effects of the drugs, or maybe it was just because my thoughts were thinking negatively. Nonetheless, she would apply these techniques on me. So it helped me. I went to sleep. But guess what? It also helped her because she was able to go to sleep. So what I'm saying is it's beyond even the person receiving these treatments. It helps the caregiver, it helps the family, it helps the village when that person has a little bit of calmness and can not need so much caregiving. And the other thing that happened to me was, remember I told you I was afraid of needles. So it wasn't just the IV tubes and the stabbing that you go when you're going in for chemo, but about halfway through, I developed neuropathy. And neuropathy, for folks that may have diabetes or have had experienced this side effect from chemotherapy, it's the numbness of your fingers and your toes. And it's the nerve endings. And they get really sensitive, and it gets difficult to button your buttons and feel that what you're stepping on, and it can be debilitating, and it can actually be a permanent damage type situation. So my oncologist said, well, I think you should maybe consider, we should probably look at considering stopping or just, slowing down the treatment. Well, there was no way I was going to do that, because I really wanted this cancers out of my body and I wanted them gone. And no, I wasn't going to do that. So what was the other option? And we discussed acupuncture. All right. So the person afraid of needles went to acupuncture. It's really not that bad. It's very, it's like a pinch. But, but I went. It was amazing. It really helped me a lot. It helped me so much that the neuropathy went away. And so I really believe in acupuncture. And finished the chemotherapy treatment, still applying the same therapies that I'll tell you about the foundation in a minute, still applying the same therapies. When you're done with your treatment or done with your cancer journey, you enter survivorship. It's an awkward little space for those that are survivors. It's awkward because your friends and family want you to move on and tell you, they're saying you're normal, you're okay, get back to normal. But what is normal after that? And it's really hard, and you want to get back to normal, and you want to be that for your family because they've been there for you during this bad experience. So these therapies, guided visual imagery, deep breathing meditation, therapeutic massage, acupuncture, they're all good for you all the time, even after cancer treatment and through survivorship, and helping you stay focused and help you stay positive and help you stay the course. And one of the things that most people don't talk about is the financial element of having an unexpected disease enter your life. Most people don't talk about that. But usually, it's either the person going through that disease that's not going to work, so they're going to have a reduction in salary, or it's going to be their caregiver because they need to be around, so they're going to reduce their hours. So you see your finances going down and your expenses going up because you didn't plan or prepare for the unprepared thing. So now you have your co-pays on your health insurance, whatever that plan is, for all of your expenses. You also have your pharmaceutical co-pays. You also have the fact that you're going to UCSF, so you got your $5 or $6 every time going over the toll with the bridge. You also have your parking, which 5 to 10 minutes in the parking lot at UCSF is $20. So it gets costly, and it adds up. And those are the things people don't talk about. So we are fortunate. And we think we spent about $5,000 or $6,000 on these healing therapies. But we were fortunate that we could do that. Not a lot of people are that fortunate. So after cancer treatment, and in 2008, I took 2 years off of work. So we lived on Gracie's salary and stayed fully dedicated to start the Sandra J. Wing Healing Therapies Foundation. And we did that. We're really proud of it, and what we do is we provide financial assistance to cancer patients here in the Tri-Valley area, and it's real tangible stuff. And I'm just gonna, by the way, this is me going through cancer treatment, and some of the things that the therapies helped me on was all that I'm listing up here, and I talked about the nervousness and anxiousness, and I was really fatigued during that time. I was so exhausted that just going from my bedroom to the living room, I was tired. That was exercise for the entire day. So these are things that other people that we've helped have said how these therapies have helped reduce these conditions in their lives, these side effects: nausea, constipation, stress. Most importantly, staying the course. And these are some things that the therapies help the people with: improving mobility, inducing relaxation, increasing the appetite. And these are just some testimonials of folks that we've helped. What's really cool about our foundation is that it's here. We're making a difference with people going through a really crappy time in their life right now. We're helping them to stay the course, follow the treatment, follow the chemotherapy, follow the radiation, stay the course. Because you go to the treatment, you get beat up, right? You feel like, I don't know how a lot of you felt, but I felt like a baseball bat had just hit me after every chemo treatment. Battered and bruised is kind of how I felt. And these things help that person to go, okay, in 3 more weeks or next week or whatever it is, I'm going to have to do this all over again. I'm going to get enough energy to do this all over again. And so just Sunday, I was at Safeway here in Pleasanton, and there was a woman who clearly had no hair, and Gracie went up to her and said, "Are you going through cancer treatment?" And she said, "Oh, yes, I am." And Gracie said, "Well, have you heard of the Sandra J. Wing Healing Therapies Foundation?" And she said, "Well, yes, I just got a grant from them." And she walks over and introduced her to me. And that's how tangible this foundation is. We are helping people, running into people in our town that we're helping. And I know we've helped a number of you here, and that's what we're all about. And the table over there, if you just wave your hand, over there, okay, in the corner, if you didn't stop at our booth tonight to ask, about us or find out about us, I hope you will tap one of these wonderful folks. We've been really proud. We have 100 volunteers, and we just surpassed, after 5 years of issuing grants, our 500th grant. So we're really proud of that, and so thank you.
Okay. Well, thank you very much, Sandra. That was fantastic. Well, this concludes our program. Thank you so much for being here and sharing your story with us. With that, I'll conclude our symposium, and we'll look forward to next year. Thank you very much.